Okay, so morning. Sorry about that. I don't know what was happening. It just didn't want to connect and it just didn't want to open. So, nasal emergencies. I think something we see quite often in emergency departments, unfortunately. And it's an interesting topic, so we'll try and get through it. The most common emergency we see is epistaxis. All right. And it's potentially life-threatening. And it depends which one you have. So we're going to cover a few things and we'll look at some techniques and things like that to try and help. So the most common anterior epistaxis, which takes place here at the Kesselbach's area, all right? So, and then posterior, which takes place in Woodruff's plexus, all right? Anterior normally doesn't present such a big problem for us. You know, anterior is quite easy, you pack it and things like that. But this is the one that always tends to trump people, right? The main reason being that it's this branch of the sphenopalatine artery is very difficult to compress and get through. I mean, all that we're doing in epistaxis is we're applying medication or pressure to help to constrict the vessels or tamponade the vessels. That's about it, okay? So anterior bleeds. Anterior bleeds extremely simple. There's really nothing to it, all right? You have the patient pinch their nose and bend forward, right? I've seen a lot of people bend patients backwards. Yeah, backwards is actually worse, all right? It increases the likelihood of aspiration, all right? So by bending forwards, you're pressing on that Kesselbach's area and you're increasing the amount of pressure through tamponade that's occurring over there, all right? The other option is that, like, for instance, if your patient's bleeding quite heavily, if you don't have time to stand and pinch them, or you know, whatever it is, you take two tongue depressors stuck together around the 3/4 position and function as a nasal compression device. I'll show you guys just now, right, how that works. So what that does is it just pinches on the nose and it can also provide a lot of pressure. And it's something nice to use, especially if you're doing like clinic rotations or if you're working pre-hospital and you don't have much. It can actually save you quite a bit. Like you don't have access to adrenaline and things like that, all right? Ice packs to the forehead, all right? So it doesn't do much. Sometimes causes a bit of vasoconstriction. It just tends to make the forehead a bit cold and it stimulates a bit of a vagal reaction. So with the vagal reaction, you get a drop in heart rate. So that sometimes contributes to it. But the actual application here doesn't do much because origination, it's only the ethmoidal arteries that, and the frontal sinus arteries that is, most of your blood supply is coming from the bottom or from the lateral sides, all right? If you have patients where it's due to high BPs, you lower the BP. For the simple reason that it's like any tube. If you have high pressure in a tube, it's going to push out more. Lower the pressure, it goes down, right? The problem is that if you have a patient with long-standing hypertension, they tend to have frailty of their vessels, intimal damage, things like that, because of years of hypertension. So most of these patients need to be tamponaded overnight, BPs controlled overnight, given things to help them clot. And even with all of that, they may still rebleed, okay? So with a lot of them, once you get the BPs under control and if they're still bleeding, you just keep that pack in, that nasal pack, all right? And then if you have silver nitrate, now I'm not sure, have you guys seen our silver nitrate pencils here? No, because they don't have them, all right? So silver nitrate, if you have it, it's great. But there's a few things that make it a bit difficult to use. Number one, you have to have a bloodless field, all right? So if you don't have a bloodless field, all that's happening is you're applying silver nitrate to blood. It doesn't really help everything. And then you've got to go proximal to the vessel. So that means you don't actually apply on the bleed. You're trying to cauterize chemically proximal to the bleed, all right? And you can only use it on one side of the septum at a time. Because remember, it's causing chemical cautery. So you're cauterizing on one side, cauterize on the other side, you may just get a perforation of that septum. So we do have to be a bit careful with it, all right? But we'll talk about it a little bit more. So these are silver nitrate pencils, all right? One particular brand that you get, okay? So essentially what you're doing is that you just pass it into the nose, you suction, and then you just try and cauterize all of those by just applying it lightly. You just rub it over. So by chemical cautery, it just causes vasoconstriction. And silver nitrate has a lot of uses. It's not just cautery, you know, granulation tissue. There's so much that you can use it for, and it can really help. And then this is the splinting device that you can use. So that helps quite a bit. So you take two tongue depressants, you just break them, or one, and you break it, and then you just apply a rubber band. So what happens is it just creates basically two fingers that can hold your nose plugged. That's about it. But this is the most common thing that we do, all right? Anterior nasal packing, all right? And it's the easiest way to sort out the problem. It just depends what you've got available. So ribbon gauze is the best. We don't have ribbon gauze. So we just use normal gauze that we kind of stretch out. But the most important thing is just to try and layer it a little bit. So in other words, you're not just putting a piece of gauze there. You're trying to get as much gauze in as possible, you know. So sometimes if you have to use like 2 or 3 of our normal gauze, the most important thing, you don't want it to get lost inside. So you pack as much as you can, leave a little tail out. Pack as much as you can, leave a little tail out. You just keep on doing that until it's packed, all right? So yeah, so it's done if localized bleeding is profuse or the bleeding point is not localized. Ribbon gauze soaked in liquid paraffin is ideal. We do it soaked in adrenaline and cyclocapron. I would advise you guys to do that. They've actually done studies where they just, as we apply adrenaline directly onto the pack, we apply cyclocapron directly onto the pack as well. It does wonders. It actually helps the patient to clot much faster. Right? So you can do it in whatever manner you choose, horizontal, vertical, can be removed within 24 hours, can be kept for up to 2 to 3 days. And then systemic antibiotics should be given to prevent sinus infection and toxic shock syndrome. All right. Now, this is something we sometimes forget because most of our patients come back the next day, so it's not much of a big issue. But if you are keeping it in for a long time, sinus infection is quite understandable. Toxic shock syndrome, do you guys know? It's more commonly associated with tampon use and things like that. But the truth is any pack, all right? So what happens is you get the release of, which organism is it again? Staph, yes, that's for sure. So it's a release of a large amount of staph, all right? And then that basically leads your patient to go into septic shock. Okay, so it's something that we should try and avoid, all right? So by using adrenaline and cyclocapron, you achieve hemostasis faster. You can pack bilaterally if needed, all right? Sometimes that adds just compression from the other side. It also helps to just pack the vessel a little bit and prevent bleeding, all right? But if the bleeding continues, then the problem is that you may have a posterior bleed, okay? And that's the one that we need to worry about. For the simple reason that they tend to be more profuse because the artery itself is quite large. The supplying artery is much larger and the access to it is much less. You can't actually see that Woodruff's plexus from the outside unless you have a nasal speculum, you have a, nasal scope and things like that, all right? Now, when do you consider a posterior nasal bleed? If you can't see the actual anterior bleed. So in other words, you're looking at the thing, but you can't actually see bleeding from Kesselbach's plexus. Or it's like oozing past, but it's not actively bleeding from there. So then you start thinking about that. If there's bleeding from both nostrils, you've got to start thinking that it's a possibility, you know? So you've got to think about that. If you've got blood in the oropharynx, that's quite common because anterior bleeds generally, it all tends to come out this way. Posterior bleeds, you start seeing blood go back. And then you've done bilateral anterior packing and your bleeding is still carrying on. Then you really got to start thinking about a posterior bleed, all right? So the question is, how do you treat a posterior bleed? Any ideas? Yes? Yes? What do you do? Do you slap it against the patient's cheek? I'm just joking, don't worry. Yes, you're 100% right. You pass it through, inflate it, and try and pull it back, which is much easier said than done. Okay, so there's a few ways. We're going to talk about the way that we're going to use, which is the Foley's catheter, but let's talk about some of the fancy methods. So if you're doing a locum in Umhlanga or Santon, or you end up going to Canada, Ireland, one of these places to work, you'll end up using some of these things. So know about them, because the worst thing somebody could tell you is get a rapid rhino, and you're like, bloody hell, there's no zoo in this place. Do you get what I'm saying? So it's nice to know what these things are, and we're going to see something. We're going to watch a video about them now, right? So there's a few things. There's nasal tampons, all right, which is self-explanatory, all right, Mirosil. So it's a tampon, basically. It goes into the nose, and it tamponates, all right? It swells up as the blood infiltrates it, and that's about it. Rapid rhino balloon device is basically a specialized catheter that's developed just for the nose. Okay, so that's why rhino, nose, okay, not the animal. Okay, epistat, also similar, also or what you call it, epistaxis, all right, epistat, immediate. So it's also been specifically developed for the use in the nose. The hemostat foam flow seal is also a very good thing that can be used if you have access to it, right? It's actually one of the best devices. The problem is none of these appear on our emergency trolleys. We don't have money for this in our public service. In the private, some of the hospitals, not all of them too. If you do have epistaxis and you go to some of the private hospitals, the most I've seen in ours is Mirocil, and that's it. I haven't seen anybody with the epistat balloons or anything in any of the emergency departments I've been to in private. Okay, so what you're going to do is we're just going to have a little look at what would we say is ideal emergency management, the management of epistaxis. So in other words, you've got access to all these things. All right.
Here are some tools and products that you need to know how to use for epistaxis. First, you're going to need some suction to get the blood and the boogers out. You also want a nose clip to help clamp bilateral pressure on the soft part of the nose. You need a nasal speculum. Remember, it opens superior, inferior, not laterally. Don't injure the septum further. And you may want to have some bayonet forceps to help place that packing material. And hey, speaking of packing material, here it is. Starting with Mirocell, it's a nasal tampon, comes in various sizes. You're going to smear on some antibiotic ointment on the outside. And remember, when you insert it, you hold it like this and you insert it horizontally, parallel with the patient's palate. Next is the Rapid Rhino. Remove that outer covering, and you're going to soak this in sterile water for 30 seconds. That activates that spongy material, which helps activate platelets. Again, insert it horizontally, not upwards, and then inflate the balloon with 10 cc's of air. And this gets taped to the patient's cheek. All right, let's do the big guns, the posterior packs. This one is the EpiStat. It's an open catheter to allow for airflow, and you're going to inflate that posterior balloon with 10 cc's and pull gentle traction forward. Then you can inflate the anterior balloon, which holds up to 30 cc's, and you may not need that much. This is another example of a balloon catheter device. Inflate that posterior balloon with 10 cc's, pull gentle traction, same technique here, and then you can inflate the anterior balloon also with 10 cc's. Now, these are just a few examples. There are a lot of products out there. We have no affiliation with any of them. We just want the bleeding to stop. Let's review some insertion techniques. The most important thing to know is that you insert it straight back, level with the patient's palate. Do not angle it up towards the brain. Same technique for the posterior pack. And remember, you're going to remove any other packing material before you place the posterior device. Now go stop some bleeding.
All right. So how many of those things do we have available to us? Not one. No nasal speculums, no bayonet forceps, nothing. We've just got all the basics, all right? So the question comes then, what do we do?
Here are some tools and products.
So we have the humble Foley's catheter. Good old Foley's catheter that's supposed to be inserted in the urethra. And that's the only thing that we have. There's nothing else. And in most situations, this is all that you will have. But notice, even though you've got all those fancy devices, your Foley's catheter is providing the same basic fundamental packing method, which is tamponading, pressure tamponade to the posterior. Now, what I can tell you is that insertion of this is much easier said than done, all right? So I just wanted to show you the first method that was initially developed for posterior packing, all right, before we get to the Foley's catheter method, okay? So what used to happen before, the original way of doing it was that you would bundle your gauze all together, all right? And you would keep it on suture string. Then you would pass the suture string around the back, or you'd pass your catheter around the back, depending on what you had. And then you would attempt to, attach this to the catheter and then pull it all the way up, all right? Extremely uncomfortable, all right? Because the only way to get this in is to actually shove your finger down the back of the patient's throat as well, all right? As much as you are pulling traction, it kind of gets stuck just in this area, and you need it to move around behind there. So you end up having to push your finger back at the back of the patient's throat and trying to angle the packing up. So this was how it used to be done initially, before somebody stumbled across the Foley's catheter method and said, holy shit, this might be a little bit easier than trying to do this, okay? But at the end of the day, the basic idea is the same, all right? We're trying to get everything. The reason why I'm showing you this, it's too bad Dr. Nkwasi is not here. I don't know if any of you guys were on call that night when we had that patient, that severe posterior bleed. Okay, this guy had a fracture from a punch, right? So it fractured the entire nasal septum. So that septum was just moving around all over the place. And we inserted a nasal catheter, a Foley's catheter. And if you put 10 mils inside, it can't move beyond this area, okay, because of swelling over here. And if you put anything less than 10 mils, it just shoots through because the entire septum is disrupted. So it needed 10 mils. So in that case, I stood with him and we had this thing floating around here for I think about 20 minutes. It refused to go. Every time we deflate, it would fly through, things like that. And eventually I had to use this method to actually get it into the patient's nose. So we kept it at 10 mils, had to physically force it past this hard palate at the back, soft palate at the back, and then get it into that area. So this is the reason why I'm showing you. Sometimes it will not move, no matter how hard you try. You'll see the Foley's catheter, that balloon just sitting in the throat. You just got to tell the patient, sorry, put your finger inside there, pray that they don't bite, and then push that thing through, all right? So that's the reason why I wanted to show you this, okay? But this is the one that should be used, all right? So it's quite simple in theory, and in practice, very, very difficult for two reasons. Number one, it's extremely uncomfortable for your patient. You've got this patient that's trying to vomit over you all the time and who's bleeding now, all right, at the same time. So you're introducing two irritants into the throat. So this patient is extremely uncomfortable. They're moving, they're not happy, they're bleeding. You know, it's just not a good situation, if I put it that way. They're coughing, they're sneezing, blood is flying everywhere. It's horrifying. And then the best part is, as soon as you start putting this down, and as soon as you get it into that area, the gagging stuff, you know, and you get scared. And it's not nice. Let's just put it that way, all right? But essentially what you are supposed to do, is that you pass the Foley's catheter down past the soft palate. So in other words, you should see the tip of this just pass below your field of vision. So you're looking into the patient's mouth as you pass it through. You see it pass down there, and then you inflate it with 10 mils, all right? 10 mils is general, all right? Some patients may be smaller, some patients may be larger, but 10 mils is generally how much it takes. Some of the books say inflate with air, don't inflate with water, because there's a risk of aspiration. Your patient is bleeding so much, that is fluid going down. If for some reason that catheter bursts, 10 mils of fluid is not going to kill them. It's the 400 mils of blood that they are losing that pose a greater danger, and the water gives you a better temper. Okay. Some of the books also say cut off the tip so that it doesn't irritate the back of the throat. The problem is you may just snip the balloon at the same time and not realize. So what I would advise is just keep it as it is. Pass it down there. As soon as you see it inflated, as soon as you inflate it, the gagging is going to get worse. That's when you've got to put traction on it and try and pull it back into the skin. All right. That's sometimes the difficult part because it refuses to pass. Your patient is gagging, the throat is moving. They are moving around all the time. So that's when you've got to know how to be able to, sorry, I just want to see who's not muted. So that's when you've got to be able to push your finger there and be able to push it back. And that's the only way that it works sometimes. And sometimes you've got to do it bilaterally. So you've got to put a Foley's on this side and you've got to put a Foley's on that side. Okay. I looked high and wide for a video that describes this. There's nothing. Because I'm guessing the only place that we use this technique is in situations like ours, where nobody's running around with fancy recording devices and you've got to save the patient. So throughout the world, nobody's got an instructional video on how to use a Foley's catheter, okay, in order to do it. All right. So basically, you insert, push until you see the tip, inflate with 10 mils air, sterile saline, then retract. But sometimes when you're retracting, you may think you have put 10 mils, some may have leaked out, and it may just pull through because it needs to be inflated a bit more, right? If it does, however, come through with 10 mils, then you instill another 2 to 3 mils, all right? And then you repeat until it can settle itself against that posterior compartment, all right? And if there's pain, so if the patients experience severe pain and bulging of the soft palate, so the thing starts bulging forward, then there's too much of pressure, all right? And it's providing, it's actually starting to cause necrosis and direct pressure on the periosteum of the, hard palate, just release a bit of pressure as well. Okay, so sometimes you may overinflate. So that's what you've got to be careful of, all right? The other thing that you've got to worry about is the anterior part of the nose. Because once you've got that Foley's catheter sitting over there, it's an irritant, and there's always a possibility that it's going to cause excoriation. So just put something on the exterior part of the nose. Just a little bit of gauze, something, whatever you've got, just to protect that bit of skin on that nasal area, okay? See what I've got now. So do you guys understand? We can stop here for a second if you have any questions. because it can get very difficult. Posterior bleeds are one of those things that I dread because I know I'm going to get called out to come and assist you guys because it is difficult. It takes practice. It takes time. You must have done it a few times. But what I would advise you guys, if you do have a posterior bleed, try it. You know, try it. Get your hands dirty. Try it out once, twice before you call for senior help. You know what I mean? Just to get the idea of what is going on. Because the first time you try it and you fail, there's no problem. Somebody else will come, watch what they are doing. Then the next time you do it, you'll be a little bit more comfortable. All right. What some people do as well is they just spray a bit of xylocaine into the throat just to assist the patient a little bit. Okay. If you do decide to do that, it's not a bad idea. The problem is a lot of people feel that xylocaine is spritz, 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 spritz. The dose of xylocaine is one spray. Remember that, all right? If you go above that, there's toxic reactions that can take place, all right? The patient suddenly becomes cyanosed, you don't know what's going on, you draw their blood, it's nice and dark brown, it looks like chocolate, and you're like, and you are killing your patient. You're giving them something called methemoglobinemia. So you've got to be careful, all right? So xylocaine, anytime you use it, just remember, one spritz, that's it. That's the dosage. So aim it correctly and use it. All right. When we say one spritz, I mean over that area. So if you've covered only half, of course you spray on the other half, but don't keep on spraying on the same area all the time. Okay. So I hope you guys understood epistaxis. It is difficult, there's no doubt, but the only thing at the end of the day is you're just trying to apply pressure to that posterior plexus. And even with that, you've done that, your patient now needs transfer to an ENT. The reason being they cannot live with the Foley's catheter in their nose. Okay, they need to see what caused this, what's going on. In our, like with our last patient that we had, it was due to trauma. The septum needs repair urgently. They need electrical cautery. They need clamping of the vessels in some cases. And I've seen cases where they actually have to do full exploration. In other words, go in, find the sphenopalatine artery, the main branch, and clip it there before they can do repairs. So some of these are quite involved. Okay, so basically our job is stop the bleeding, get the patient to an ENT as quickly as possible. Okay, if you're working in a place that has one of those fancy devices, insert the fancy device and still transfer to the ENT. Okay, now the next favorite thing, nasal foreign bodies. Okay, we all love them, isn't it? When you pick it up off that tray, you're like, yay! This is my patient. I'm definitely not putting this patient this far down. Okay, so there are some contraindications to removal in the emergency department, just before we talk about removal. Okay, so if the airway is at risk, or if you have an unstable patient for whatever reason, all right, so the patient may have aspirated something before, the patient may have had injuries to the face, I don't know, I'm just giving you examples. Okay, foreign bodies that are impacted, all right, when we say impacted, what it means is that it's really stuck into the tissue, it's penetrated into the tissue. The reason being, you don't know what it's tamponading over there. If you remove it, you may start a bleed. Okay. If it's already causing severe bleeding, in which case you just need to pack. And if it's perforated the septum, so it's gone through the septum, don't touch those. Okay. Those need a specialist to have a look at them. Uncooperative patient and your ketamine is out of stock, Domicum is out of stock, don't attempt it. You're going to cause more damage. Now, this is normally with the younger kids, all right? Older kids tend to tolerate a bit. And then, of course, if you have adults who are just extremely anxious, those who've got developmental disorders, things like that, you do have to be careful. The most important thing is you don't want to make that damage worse, okay? And then large foreign bodies behind the middle terminate, okay? If you can't see it properly, don't touch it, okay? So if there's something there, maybe you can see it on X-ray, you can palpate it, but you can't see it, don't attempt it, all right? There's a reason why we have ENT specialists. Use them. Your patient's not going to die from this being stuck in the nose. They are going to die if you dislodge it and it goes backwards. They are going to die if you cause them to start bleeding. Okay, but just the fact that it's sitting over there is not a major issue. It's a relative emergency. They need to be transferred as soon as possible, but not necessarily that it needs to be removed every time. Okay, so some of the things that I wish we had. Some fancy stuff again, all right? The reason why I like to show this is just so that you guys have some background knowledge, all right? And that you'll know that these things exist, all right? So this is a lighted forceps. So what it has is it has a viewing box, it has a light source, and it has a grabbing forceps at the front over there. So basically what it does is it lights the way, and then it has the ability to grab the foreign body as well. Can you imagine how easy our life would be with something like this? Okay? It doesn't even look that expensive. But we can't get it. We just can't get it, all right? And you get some really fancy ones. They come with fiber optics and things like that, but we just don't have. Okay, so this is called a CATS extractor. So it works in a similar principle to the tamponading balloons. Basically, you go past the foreign body, then you inflate, and then you retract, and you pull it out, all right? And this is a gator nose otoscope tip. So what it has is it has these grabbing arms, and it has this trigger. So you basically attach it onto your otoscope. So with your otoscope, you're basically looking through, you're having a look at the foreign body, and then just click, grab it, and you pull it out. It'll be so lovely. Even this doesn't look that expensive. And it's meant to attach to an otoscope that we already have, but we just can't get it. Okay, trust me, I tried. What this one tells you is that if you have a foreign body, and if you have a small enough catheter, you can also try it. But in truth, it doesn't really work. The reason being, this is a much more rigid thing than our Foley's catheter. So what happens is that it's very hard sometimes to pass a Foley's catheter behind the object. It tends to curl and bounce and things like that. But if you want to, I have done it, where you pass like a size 8, those mini catheters for the babies, you pass them behind because you can see them, and then you retract. It does work and it does come out. You just have to be careful of how much you inflate. You can't put 10 or 15 mils because so you're just trying to inflate a little bit and pull forward. Okay, so just remember that. So this is another one that we're going to do. So this is called the mother's kiss or parent's kiss. Okay, and it's one that actually works quite well. And for some reason, we don't do it often enough. So I want you guys to have a look at this because it really is an interesting technique and it works. We've got now.
Try this at home. However, the basic premise is that the parent or guardian blows air into the kid's mouth to dislodge something from their nose.
That's it.
You hold the unstuffed nostril shut, and if all goes according to plan, the thing shoots right out. Though it's called mother's kiss, a father could certainly do it too, or any random stranger willing to blow air in a child's mouth. Personally, I would just go to the doctor, but then I have insurance. In my research, I came across this story about a kid who had a Lego up his nose for 3 whole years before finally realizing the problem and having it removed. And apparently Legos getting stuck in noses is a big problem. Not as big as climate change, perhaps, but it's definitely...
Okay, so it's such a simple technique. So the reason why we say parents, because if children are more comfortable with the parents, if you try and kiss that child, and they're going to charge you. Yeah? So you just you just instruct the parents. You tell them what you're trying to do, all right? And you assist them as much as possible. But they just form a tight seal around their child's mouth. That's it. They block the side that doesn't have the problem and give it a good quick blow. All right, advise them not to blow too hard. They don't want to cause barrel trauma as well, but just a quick, short, sharp blow. And it really dislodges a lot of those things without having to sedate the child, without having to put instruments into the child. The child is with their parent. It makes life so much easier. So remember this technique. It saves you so much of time. And really, the parents feel happy as well. And the best part is the next time something gets stuck, they don't come to trouble us at 2 in the morning. They do it at home and they go back to sleep. All right. So remember that one. Okay. So this one here is a method that I used. All right. So we're going to just have a look at the 2 videos. Just so that you guys can.
Hi everybody, so we've got a young child over here with a common problem, a foreign body that's stuck up the nose. I'm just going to try and show it to you. Here, see if I can angle it in enough, and if she doesn't wake up. Okay, you might just be able to see the tip of it there. Always difficult because the kids generally jump around and move. So what we're going to do is we're going to sedate this patient, and then we're going to take it out. So you can see all of these fancy instruments that we've got over here. We don't need most of them. All right, what I've done, we've taken just a normal suture. We've cut off the suture on that end, and we're clipping the sharp end on this side. So I've created a hook, and we're going to take it out like that. All right, so let's get ready, and then we'll do the next video where we take it out.
Okay, so sorry, it just didn't show the thing, but basically what you do is that you take a suture, a normal suture, appropriate size for the patient that you're trying to get to, all right? You cut off the suture, so you've just got the metal part. You can either blunt the sharpened end, or you can just grab the sharpened end in your instrument, all right? And what it does is it creates a hook for you. So now you've got an instrument that you can use to actually get behind that foreign body and try and pull it forward, okay? So what we're going to do is we're going to see the actual removal of the foreign body. Now, the other things that we do, remember your patient is at risk of aspiration. So we've sedated that child with ketamine. We placed the offending nostril lower down, okay, so that there's less chance of aspiration. And we place the child in reverse Trendelenburg block, so there's even less chance of aspiration. So that's what you need to do, okay? So let's have a look. So this is the sedated chest.
I need something in the nose so I can see where I'm going. Right? All right, there we go.
Okay, light source, very important so that you can see what you're doing.
Okay, so you can also come down. All right, so we put the patient basically in reverse Trendelenburg just so that she doesn't aspirate. Here we've got our little makeshift hook, all right? So very often removers can't get behind these types of objects. Try and go, if you can, through the superior wall. Try and place a bit of pressure behind, but then you need about 7 fingers on each hand to be able to do that, right? So I can see it quite clearly. Patient is nice and sedated. So I'm just going to try and get my hook behind.
All that I was trying to do is just get that physically behind her. Right?
And it's just the angle that she's in. Oops, sorry. And my hook is a bit long. I'm just going to make it a bit shorter. Okay, so I can't control it properly, but I'm getting behind it. All right. Can you see it there? Oh, she's still a bit awake. That's why. Let's try and lengthen this a bit. So if worst comes to worst, we may. Oh no, she's trying to take it in. Oh no, she's sucking. All right. Just give me that light again. Right, there we go. Now I can see. Right. You might just have to give her a bit of ketamine again. Okay, so the hook's gone behind. Oh, she's still a bit too awake. That's why we're having a bit of a trouble. So my hook is behind the object, and my hook is pulling it out.
There we go.
And she hasn't aspirated.
Okay.
Ta-da!
So it's a simple trick.
So let's just remember the fundamentals. Create a little hook. All right, that's from a chromic 2O, 78 rand. All right, the cost of transport down to Grace is 14,000 rand. All right, the cost of the ketamine, just a few rands. Okay, we kept her in this direction, so even though she was trying to pull it in, there's no way that she can aspirate it down this way. Okay, you get your hook behind as much as possible, but you can see how important the sedation is as well. All right, and there we go, it's out. Okay, so the problem is, especially when you've got big things like this, you've got those, you've actually got commercial removers. They can't actually get behind. So this little trick over here, and it comes out. Sometimes if you've got something that's very stubborn, you actually make 2 of these, and you put it and you pull it out like that. Okay, got all of them. Quite easy, isn't it? Right. Good. So the government can pay me for all the money that I save. Right. Let's put on oxygen now and wait for it to.
Right. So it's quite a simple trick, but it works. Right. And sometimes you do need 2. You know, if you just need to get behind and things like that. Most important is don't use the sharp end. Make sure the sharp end is somewhere else. Right. And I just wanted to show you. I just hope I'll be able to draw it here. Do they have? Okay. Let's try and use this. If you can. Okay. So the nose is actually. If you look at the nose, it's a triangle, all right? So we're just going to ignore the bottom part, all right? So that's basically what the nose looks like, all right? And then if you try and put a foreign body inside, all right? Generally, let's say most of the foreign bodies that go in are round, okay? Let's just say something like that that's stuck inside. So if this is the medial end, so that's where your nose is, all right? So in other words, your septum is on this side, and that's the exterior end. Your 2 best bets for actually getting behind the object are actually to go laterally or to go superiorly. If you try and go medially, you don't have as much space. And you've also got the turbinates on that side. Okay, so this is your best bet to go that way and that way. And if you need 2 hooks, then you go that side and that side. Okay, and it allows you to get behind the object quite easily, all right? So that was just to show you guys that. So I hope it makes sense. And even in saying all of that, it can still be quite difficult to get some of these things out, and no matter what we try, we still can't get it out, all right? The last one, insects, all right? Rare to find live insects, but it does happen, okay? You do get it, all right? So the most common presentation with the nose, it sounds like we're living near a huge airport or something in Joburg or Durban. Wow. All right. So most commonly what happens is you get a dead insect that infiltrates the sinuses. All right. And then, sorry, somebody wants to ask something. What happens if it dislodges but does not cause airway obstruction because of the reverse Trendelenburg position? Okay. Yeah, listen, that can be a problem sometimes. So generally what the person is asking us, I'm not sure who's why 6, but what they're saying is, what happens if you push it back? And now it's stuck at the back of the throat. That is a bit of a bad one, okay? Because if that does happen, now what you've got to do is you've actually got to try and remove it. So you've got your, what's the name of that forceps now? McGill's. All right. So if that happens, I would leave the patient in reverse Trendelenburg if you are not sure how to use a McGill's or how to sort out an aspiration and things like that. Generally, what we would do is that we would allow the foreign body to actually move a bit more into the field of view and then try and grab it with the McGill's. Because if you get that thing down any further, it is going to go down. It is going to aspirate. Okay. So what I would say is at the start, if you feel like, listen, if I touch this thing, it's going to go backwards, don't touch it. Just leave it at that, all right? And if you feel that, you know what, I've got a chance, yeah, take a chance, there's no problem. But if you do dislodge it and you're not sure what to do, please call for help. That's all that I can say. Well, it's quite a good question, but it doesn't happen very often. Depends on the type of method that you use. So that's more common with the crocodile forceps. So crocodile forceps has this little grabby thing at the front. And if you have a large object, what happens is that it can kind of grab the tip, but if it can't really grab it, it just ends up pushing it. So that's why I'm not a big fan of crocodile forceps in the nose. I prefer something that goes behind, because then you're decreasing the chances of aspiration. Okay, but that's why I say if you can't see it, don't even start. Okay, I hope that answers the question somewhat. Okay, so just getting back to insect. So normally what happens is you get this dead insect that it crawls into one of the sinuses, it causes an infective reaction, and then you start getting this very purulent foul-smelling discharge from one or other nostril, all right? So normally these patients need admission, IV antibiotics, and transfer to ENT. There's not much that we can do in an emergency department for a, dead insect. If you have a live insect, try and pull it out, you know, but that thing's going to try and scurry away. So you can try exactly what you tried for the ears, try instilling a bit of lignocaine, see if you can kill it, or try and flush it out, things like that, you know, nasal syringing. But it's very rare to find a live insect. The reason being your own protective mechanisms tend to cause the insect to be blown out or pulled back in. That's the sad part. The dead insects normally happen in the middle of the night, patient is a bit sleepy, it gets into that cavity, the patient doesn't even realize, and then it dies in that area. Okay, so we're going to cover nasal suturing later on, but I don't know if there's any questions or anything that anybody wants to know. I know it's a big topic, and we tend to go a bit fast. If we break them up into small bits, we'll be sitting here for years just discussing the nose, all right? So that's fine. So listen, there's no hard and fast rules when it comes to all of these things. When we're working in the emergency departments, often a case of marker plan. You know how they say marker plan, you have to try and make a plan and try and get things out and use what you have available. But these are the basic things that we have at our disposal. We've all got suture material, we've all got Foley's catheters, we've all got some form of sedation, beds that can turn into reverse Trendelenburg. So I hope these things will help you guys in the future. Okay, all right. I think we are running a bit late today, so we'll cut it a bit short now. If there are any questions, you can post it on the group and I'll try and answer there. And if you guys have any questions, you can ask me now. Okay, but otherwise we'll stop it. Okay, thanks everybody. Bye.